Welcome back, students, to Part 113 of our IPDRG Masterclass. I'm your lead instructor, Harshal. In our last lesson, Part 112, we mastered the surgical procedures for infectious and parasitic diseases in MDC 18. But today, we're shifting gears entirely. We are going to decode the fascinating inpatient behavioral health landscape with an advanced medical DRG deep dive into major diagnostic category 19, mental diseases and disorders. Grab your notepads because the clinical to coding pipeline for psychiatry is absolutely full of unexpected twists. But real quick, before we jump into today's complex psychiatric coding logic, I have a quick favor to ask. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Okay, here is our roadmap for today's lesson. Welcome to MDC 19. High-volume psychosis DRGs, neuroses, and organic disorders, CDI and clinical validation, audits and secondary diagnoses, and finally, our summary and next episode teaser. Let's dive right into Section 1. Welcome to MDC 19. MDC 19 is incredibly unique. Unlike other categories that heavily rely on surgical versus medical partitions, the dividing lines here are driven entirely by behavioral health levels of care. We are looking at primary psychiatric manifestations, things like major affective disorders, schizophrenia, or acute behavioral emergencies. For you as an auditor, coder, or clinical investigator, this primary clinical focus is exactly what sets the stage for our entire MSRG architecture. And this core MSDRG formula relies heavily on clinical and resource similarity, where every DRG starts with a base relative weight. Think of complications and comorbidities, your CCs and MCCs, as financial multipliers. Capturing an MCC represents a severe diagnosis requiring substantial resources, which rightfully pushes the claim into the highest payment tier. Moving on to Section 2, high-volume psychosis DRGs. Now, what's truly fascinating is how we differentiate the highest volume DRG families based entirely on specific clinical drivers. Let's compare MSDRG 885 and 886. DRG 885 covers psychoses, which includes the schizophrenia spectrum and bipolar I. The clinical drivers here are intense, like acute danger to self, danger to others, or active command hallucinations. On the flip side, DRG 886 covers neurotic and personality disorders. This captures severe generalized anxiety, acute OCD, and severe acute stress reactions. So the pipeline is crystal clear. A patient with active command hallucinations maps directly to 885, whereas a severe acute stress reaction lands in 886. To see this in action, let's look at a real-world case from our source files. Meet James Jett. He's a 27-year-old male admitted for an acute crisis, and his principal diagnosis is schizophrenia. The clinical drivers documented by his physician include being acutely suicidal with multiple plans, alongside new-onset auditory, olfactory, gustatory, and tactile hallucinations. Now, even with a history of crack and alcohol abuse, he's been sober for over 3 months. This ironclad documentation of acute suicidal ideation and multiple severe hallucinations perfectly supports the medical necessity for a psychosis DRG 885 grouping. Let's shift gears to Section 3, neuroses and organic disorders. Things get even more complex when we move into this partition because underlying medical conditions really start to blur the lines. Alfredo Sugarman's case highlights these exact complexities. He's a 71-year-old male with a heavy medical history, including chronic conditions like COPD and a previous stroke. But his primary presentation today? Severe depression. He feels helpless, hopeless, and he's voicing passive death wishes. He was previously placed on Lexapro and Seroquel, but right now he's refusing antipsychotics, has poor energy, and suffers from severe insomnia. How do we code this? It's a perfect example of how organic and neurotic mental disorders interweave when a patient admitted for an acute psychiatric evaluation also carries a heavy, chronic medical burden. When we code treatments for patients like Alfredo in ICD-10 PCS, we use Section G for mental health, and we can actually trace his hospital course chronologically. Day 1 might involve Character 2 for crisis intervention. Day 3 moves to Character 3 for medication management, analyzing and varying dosages to find that efficacious balance. By Day 5, we might see Character 5 for individual psychotherapy. The PCS codes literally tell the living story of the behavioral interventions over the patient's entire stay. Which brings us to Section 4, CDI and clinical validation. The absolute crucial point here is ensuring our clinical documentation integrity accurately reflects this intensive level of care so the facility survives audits. CDI specialists, you must constantly validate the difference between the primary reason for admission and the principal diagnosis. The primary reason is just that day one symptom causing the patient to seek care. But the principal diagnosis is the condition established after study to be chiefly responsible for the admission. This single code establishes your entire MDC-19 grouping. If you get this wrong, it's not just a minor typo. You face massive compliance risks, and your revenue simply vanishes into thin air. For a masterclass in clinical validation, let's look at Roger Westerman. He was admitted with severe paranoia, literally hallucinating strangers in his bed. The documented final diagnosis is delusional disorder and acute PTSD. But look at the treatment validation. Active psychotropic medication adjustments with IV haloperidol 2.5 milligrams every 30 minutes and a documented 14-day progressive improvement in the hospitalized psychiatric unit. This specific, aggressive, and highly detailed intervention leaves zero doubt about the medical necessity of the inpatient stay. You see, commercial auditors absolutely love to push for outpatient step-down denials. It's almost like a game of tug-of-war. To defend your claim, your documentation has to build a sequential fortress. First, you must prove the active acute risk to self or others. Second, detail exactly how outpatient therapy failed. Third, securely record one-to-one observation statuses and ensure daily psychiatric progress notes are locked in. And finally, actively document the group or individual therapies and psychotropic medication adjustments taking place. Section 5. Audits and Secondary Diagnoses. All of this builds the foundation for capturing true severity. We have to explore how secondary medical diagnoses interact with primary psychiatric admissions to impact your final revenue integrity. Effectively managing and documenting dual diagnosis interactions is like essential puzzle solving. For instance, capturing acute kidney injury secondary to severe dehydration in an anorexia patient, that often maps to an MCC. Drug or alcohol withdrawal co-occurring with schizophrenia can be a CC or MCC. Even severe hyponatremia caused by psychogenic polydipsia acts as a CC. Capturing these secondary conditions reflect the true, accurate severity of illness for your psych patients. But here is a major caveat that catches people off guard. Present on admission, or POA indicators. If a severe secondary diagnosis is flagged as a hospital-acquired condition, meaning it has a POA of N, it generally cannot increase your DRG weight. This exposes the hospital to quality review penalties and direct revenue loss. Your documentation must loudly and clearly state what was already present the second that patient walks through the hospital doors. Because of this complexity, a huge role for experienced coders and CDI teams is raising concurrent queries. You have to untangle sequencing conflicts. For example, is the admission primarily for the medical stabilization of drug toxicity after an overdose, or is it primarily to treat the underlying suicidal psychosis? Getting the sequencing right between a medical principal diagnosis and a psychiatric one changes absolutely everything about the final claim. And that brings us to Section 6, Summary and Next Episode Teaser. To sum it all up, mastering MDC-19 requires you to connect the dots. You have to link acute clinical risk to the correct primary psychiatric manifestation. You must use ICD-10 PCS Section G to track detailed behavioral health route operations, and to survive audits, you need strict validation of the inpatient level of care while rigorously documenting secondary medical comorbidities to capture true severity. So we've mastered the clinical drivers of mental health today, but that brings us to a fascinating puzzle for our next lesson. What happens when psychiatric conditions clash with severe substance abuse? How do we sequence claims when drugs or alcohol strictly dominate the clinical picture? We'll decode that exact scenario in Part 114, covering MDC-20, alcohol and drug use. Will the psychiatric code or the substance abuse code win out? You'll have to join us to find out. Until then, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'm Harshal, class dismissed, and I'll see you in the next explainer.